What comes to my mind from what I've been hearing is context is incredibly important. I hear caution. I think I heard lots of people talk about caution. Caution with fluids, caution with blood, caution with temperatures, and continuous monitoring. That it's not a one-off thing that we're looking for. We're looking for a child who may be deteriorating. Perhaps we need to stop it before we get to the sort of child that we've been talking about. But I'll hand over to my co-chair.
Hi, thank you very much for all the presentations. I'm Florencia, I work in Geneva in one of the operational desks. So I'm a pediatrician by training, and now I'm managing programs in different places. My question is joining what was asked before. How do we translate this in something that helps our teams in the field today? How do we rationalize the efforts? Because we talked in these presentations a lot about the trajectory and how we can identify those patients to whom we will do less harm and would actually do something to save their lives. So how can you help us to think, where do we put the efforts, and how do we help the teams that go in the field to actually, do better and not to feel lost on what they can do? Okay.
Who wants to start? Do you have a mic? Oh, yeah.
So I came to this meeting on the assumption that, or my thoughts were that having commissioned a systematic review and then having all the heads of the various parts of the organisation from different countries in Brussels at the meeting, an algorithm was decided there. David, you were there, weren't you? And where has that got buried? I mean, you're saying, I thought that was developed, and so maybe David might want to comment.
It's still there, yes. The thing that I was bothered about was the size of the bolus and the frequency. We were looking, I think, and it was discussed about 10 mils per kilogram and then review after a while, rather than ploughing in with up to 60 mils per kilo, which is a very high amount. So that's all I can really recall, and I don't know what happened after that, but I was going for small volumes.
I think we spent a long time yesterday talking about what is shock, and it became very clear from all the group is that actually everybody felt uncomfortable about saying, well, from now on we can't say for the children relevant to the feast trial, they've got shock but do nothing. I mean, they want to have something that you can say that they're a high-risk group, they need monitoring, and I think it was also the way that we describe them, whether it's severely impaired perfusion. The word shock instantly has connotations with it. I'm going to pass the microphone down because there was a lot of discussion about that.
Take this off then. I think having agonized over the feast data for a long time, to pick out what might be given as a thought to people going out. The one is that the ability to identify the group of patients who should be treated differently maybe requires not just using a word like shock, but saying we have got cardiovascular physiology, we have got respiratory physiology, we have got oxygen delivery in terms of oxygen, and we have got the metabolic environment, and we've got brain function. And maybe we need to ask in every patient we see which system is actually failing. Because there were, for example, the group in feast that had extremely high lactates and extremely low hemoglobin, that group can be identified by a hemoglobin measurement and a lactate, and they certainly are harmed by fluid, but they can be identified as needing something different. The group of patients who we couldn't see any harm or benefit either of fluid, there was a suggestion of a slightly lower curve, were identified as being in profound respiratory failure and profound brain failure. And I think that group, maybe we need to focus on the rest of things that we've been talking about later other than fluids. How do we deliver some form of oxygen support, whether it's oxygen or CPAP, and fluid doesn't enter into the picture. And so I just wonder if what we need to be moving away from is one recipe for something which is certainly poorly defined by just tachycardia and capillary refill, because you'll get prolonged capillary refill and extreme tachycardia even if you've got very low oxygen carrying capacity or very low oxygen. So we maybe need to be training people to distinguish which physiology is going wrong before thinking of a universal thing that you have to give fluid in it. And I think the other thing perhaps to say is that doing an intervention and having some form of reassessment of what you've done, whether whatever the intervention is, and obviously that's what an intensive care unit is, it's the ability to monitor what you've done, but thinking of ways in which we can detect changes that are either good or bad. If things are moving in the right direction, keep doing what you're doing. If they're moving in the worst direction, you certainly need to change strategy.
I think the comment that I would start with is the control piece of the feast study was not doing nothing. It was starting with fluid at a gradual rate. It was providing oxygen. It was providing hemoglobin where necessary, and appropriate antibiotics. And I think no one would suggest we don't do those. I think one has to start with those. I think the next piece, and it's just fascinating listening to some of the early presentations about how often patients are actually being assessed. I mean, at one level, you can't treat a shocked patient, whatever that is, by a once daily observation. There has to be some focus on trying to say, how do I assess them more frequently? I understand the resource constraints, but there may be ways of focusing some sort of attention and streaming for those patients, and that might be one way that you can approach it. And at least, as Mike says, if they're getting better on what you're doing, then just keep on doing it. If they're not getting better, well, then you've got to think of other options, and that may be difficult. It depends on what's available.
Yeah, just very briefly, I maybe don't comment on the fluids now, but I think it's very important that the clinical team and operational teams work very closely together, and that we create a very efficient patient circuit, which allows us to identify children very quickly on admission and identify the high-risk group, which we treat on a centralized critical care unit. That has implications on logistics, on human resource management, and also quality of care. And our identification of sick children who are already admitted is another key element. And we need to think on how we distribute our staff over 24 hours efficiently and how we have good surveillance on the units.
May I say something? Yes. I think that we do have some guidance, and that is clearly the ones who are very anemic need blood and not fluid. Oxygen, ABC, you know, that sort of thing. So we have that group. We haven't, you know, there's a group that were not in the feast study, and that is the severely dehydrated. And we have to acknowledge that the guidelines that we use are not strongly evidence-based, but we have guidelines that we can use, and those are Plan C. Trauma, I think, you know, if you're losing fluid, you get malnutrition, a whole different group. We don't have evidence base for them. I think it'll be coming at some stage, but for the moment, I think we have something at least to guide us. Then we have this group who are the feast study, And we have to do everything else, our A, Bs as well as our Cs. And then when we come to C, C stands for caution, yes? And I think we have to be careful. Now, being a great compromiser, if I must stick with Cs, I have to say that every now and again I do give fluids, and I have to bow my head and not look hard at the person at the other end on the table. But you do have to have some sort of guideline for your staff who are going to work and who are going to monitor this child when you're not there with all your background knowledge of physiology and everything else. So again, I would come to you, really got to be simple. You can divide it into malnutrition, anemia, burns and trauma, and then you've got the child where you haven't got any of those, but they're still impaired or severely impaired circulation. And then be cautious with your fluids. Now you're going to say, what is cautious? Well, that's what we could all argue about.
Yeah, we have one question, and one question.
Hi, I'm Elizabeth from Boston University and Boston Children's Hospital. Thank you for those very wonderful talks. The question that I had, since our first speaker highlighted the high rate of mortality in the first 24 hours of life, is whether there is a role for early identification of critically ill patients in the community prior to arrival in the hospital as part of a comprehensive critical care framework, whether that would change their experience as hospitalized patients.
Sorry, perhaps I can come in again. I really like the fact that you say critical care starts from the home onwards. Everybody tends to think it's an ICU. ICU is last resort. And we should, I absolutely agree with you, we should be teaching danger signs, not simply to our staff in hospitals, but in health centres, in our health posts, and our mums. Yeah. That is that makes it sound rather simple. It isn't, because they have to get to places. You know, it's quite difficult, but I think that's where we should be going.
If I could just add to that, when we looked in our setting who arrives in ICU, the majority of the sick children have actually been sick for several days, if not weeks to months, before they actually come in. I think to me a huge warning sign is the child who keeps coming back to the healthcare facility, and I sometimes wonder if that shouldn't be put as a marker, as almost a red flag, that something is going wrong, and get them in to be seen. So I think that you're absolutely right. You have to start and move them through. Sometimes we actually, when you look at how people get to hospital, even in well-resourced situations, we make them jump through this incredible number of hoops to actually get to the system. And actually empowering people at the village level to say, no, you need to go straight to that place, may be something that is useful if that transport and that system is available.
Yeah, this is working. So we're currently doing a transfusion trial, and what became quite obvious to us is that the actual journey of the patient often started a long time before they actually arrived. So they were travelling to the blood rather than the blood going out to the peripheral health centres. And that probably is probably one of the reasons why children with severe anemia present in such a mess when they get there. They have a very high early mortality. And so getting the system to work to get the blood to them rather than them having to take an astronomically difficult journey to get there is, and so hopefully we'll have information to sort of have a look when we finally have our analysis next year, whether that actually will affect outcome.
Hello. So we got a question.
If you just continue talking.
Voice sensitive.
Yeah, exactly. So we got a question via Twitter, and this was related, or this actually to Kathryn Maitland. And the question is, which randomized control trial would be more useful to push for in shock management in these resource-limited settings?
Which one would be most useful?
Yeah.
Well, I think FEAST was fairly useful. But it's clear that people are struggling. And so the next steps that where people are giving lower, slower, less bolus over a longer period of time, maybe that could be tested. I don't know, because I think that there is a great reluctance to just give control, which is 4 mils per kilo per hour. But that's what the control arm received. But as Andrew said, this was also a trial of implementing ETAT. And so they got all of the groups got a whole pile of other intervention. I would have thought one of the most interesting trials from some of the discussions today is adding extra health personnel, whether you could do a randomized trial of that, whether that improves mortality. I think it probably sounds like it's probably the biggest thing that you could do. Anybody want to? I was asked, but I'm sure everybody has a third on the floor.
One question, and then a last one over there.
Okay, I don't really have a question. I just want to thank Liz, because I think we're all aware that it's complex. I mean, we don't need to tell each other, and it's very interesting to hear how complex it is. But our job is to translate this complexity into something that is feasible for people in the field who are very often not doctors, who are confronted with these situations. And I think this is our task, and the ongoing task would be to define how we can contribute to the evidence that is being created in order to underline that what we want to do is not just something that we plucked out of our heads, but that is something that is scientifically proof. That's all I wanted to say.
Can I just get back to FEAST and fluid boluses? Looking at the BMC Medicine 2013 article, which you quoted, you showed us that throughout the range of hemoglobins, boluses were bad. But when I look at the actual chart, it seems that at higher hemoglobins, there is less risk of harm from fluid boluses. And I see that above a hemoglobin of, say, 8, there's no statistically significant difference in the hazard ratio of death. And my point is, we have got hemocus, we can get hemoglobins quickly, and we might feel reassured by a healthy hemoglobin in a child who hits, say, WHO shock criteria, as they're printed, and then feel confident to give a fluid bolus. What does the group think about that?
The highest risk patient in the trial was actually a child with a hemoglobin of 7 who didn't have malaria. So I think to try and just look at tiny subgroups and not look at the extrapolation across the whole group. I mean, they had a lower mortality with a higher hemoglobin because they were less sick. And obviously the difference was less critical. But I think the consistency was across all hemoglobins. I'm sorry to say.
If I can make a comment about this, and trying to analyze things by splitting categorically into you're above such a thing and below such for any of the variables you've got, when patients have multiple things going wrong. So if you try and separate the people in a study or that you're treating just by one thing, by their hemoglobin or heart rate, you will always have people on both sides of that cut with the other physiologies that you're dealing with. So it's just a thought that attempting to interpret that linear relationship with hemoglobin without also separating who has the lungs going wrong or the brain going wrong may make it difficult to interpret. And that's what the clustering analysis we were trying to do, is saying in a group of people whose hemoglobin is good, whose lungs are good, whose brain is good, what happens? And I think that's what the clustering analysis was trying to get at.
One question over there. One here, yes.
Okay. J'ai revu à l'étude FISC qui a montré de beaux résultats et des recommandations qui sont découlées après. Mais ma question revient, dans l'étude FISC, on n'a pas tenu compte de la malnutrition et des diarrhées vomissements. En revenant par rapport au contexte de terrain, où on trouve que la proportion des décès liés au choc, il est beaucoup plus pour les enfants malnutris qui ont des diarrhées. Pour que l'étude FISC puisse aider au mieux les gens qui sont au terrain, n'est-il pas aussi nécessaire de faire cette étude plutôt en incluant les diarrhées et les enfants malnutris? C'est un peu ça ma question.
Thank you very much. Maybe I can quickly translate. The question is about the fact that children with gastroenteritis and malnourished were not included in the study, and of course these are the children that we see most in our field. So it would be interesting to see what would happen with the FIS study dedicated to these categories. And maybe I can just add, what do you feel about bolus in this, leaving aside maybe the malnourished, in children with severe dehydrated? Are you still that confident that bolus shouldn't be used?
So I definitely would say that for the bolus and rehydration protocols from WHO, rather like before the FEAST trial, has never been tested in a clinical trial. So that still remains that guideline needs to be looked at in a separate trial before I can make any comment on whether this is a good thing to do or not. Most of the children who have gastroenteritis don't have cholera. And so this guideline is a very aggressive guideline. If you've got shock, you can get up to 60 mils per kilo, and then you get rehydrated, no subtraction. That's a lot of fluid potentially being given over 3 to 5 hours. It could be up to 140, 150 mils per kilo. Has that ever been tested? I mean, that worries me, but I think that one needs to test it in a clinical trial because I think with the group we discussed some data yesterday, it looks like that group has quite a high mortality. But for severely malnourished, I think if boluses didn't work in well-nourished children, although they're less well-nourished than many other parts of the world, I don't think that they would probably work in children with severe malnutrition. But that's my opinion, and it's not evidence.
As I think I am the last, I would like to really thank you because, and as we have an extraordinary panel, I would like to to make an appeal for a very neglected group facing a very significant risk of dying because of shock or hypercirculation is the kwashiorkor. So particularly with the problem of albuminemia, glycolytics, we know now a bit, but there is absolutely no research. The mortality rate is very high. Most of them are dying because of hemodynamic complication. So I really need more attention is needed from a researcher, university, and to help us to make some research for this group.
So thank you very much. But I'm very sorry that, because I think that there are many more questions. We still have 1 day and a half to go on, so I think we will have time to rediscuss. Just 2 minutes, maybe, to do a little bit of wrap-up. Yesterday, we had this awesome meeting between the pediatric working group and the expert, and we were very thrilled to have this opportunity, and we prepared this list of 10 questions we really wanted to answer with the experts. And I think we were all dreaming to get this magic bullet that could really help us to treat shock properly in our fields. And when we got to the first question and we couldn't answer that, and the question was how we define shock, I think it became very clear that that magic bullet would not come up from the meeting. I cannot talk for the others, but I think that at the end of yesterday and this morning, I'm much more enthusiastic than before because I think that that question about magic bullet doesn't really matter because there are many more things that are probably more important. You told us, the people from the field told us this early morning, that most probably to have a teamwork between doctors and nurses, to have a good monitoring, to work together to identify critically ill children is much more important than define whether, when, and how we should use inotropes or not. To define different level of cares, to frame how we can step up once we achieve the basic to the following level. It's maybe more important than define whether we should give 15 or 20 milliliter per kg in the child with, that we want to transfuse. So I think there is so much we can do, and I think each one of us that is coming from the field, that is going to the field, should take the responsibility to move on about this. And I think from our side, as Pediatric Working Group, we should really try to give guidance and guidelines on how we can address the specific medical issues, and I think this meeting was extremely useful. Again, we don't have that much time, so we will not introduce everybody, but I think it's interesting if all the members of the Pediatric Working Group can just stand up so we can be kind of recognized, and during the break and during the lunch, we can maybe have people from the field and give feedback, because that's also what we need. Your help, your feedback. Please don't be shy, guys. And I'm really talking about the extended working group, so please, Anne, Mirto, don't be shy. Don't hesitate to come and discuss with us, because your feedback for us is the most important thing. And thank you very much, all of you, to be here and to give this awesome, awesome, awesome session.